All right, welcome to the Anomalies and Infection lecture. So we'll just get started with some basic anomalies and infections, not as in-depth as some of the other anomalies that can happen. Periodic breathing is the first one that we'll talk about. This is more common in your preterm babies, as it says here. Very uncommon in term babies. So if you see periodic breathing in a term baby, it's a very bad sign. So periodic breathing is where they just stop breathing for around 20 seconds and then they breathe. So they have activity like a buyouts type breathing where they'll breathe for about 20 seconds and then they'll stop breathing. It's very sporadic. It's something that's more common in utero, of course, so that's something that they do, that fetal breathing motion in utero. So obviously it's more common in preterm than term kids. And so they just aren't dependent upon their lungs or breathing for maintaining their gas balance. And so that's why they still have that periodic breathing going on. They're still doing the fetal breathing motions. It's just outside. So it's more common in preterm babies than in term babies. If it's something that they're looking at, it's unknown really ultimately in what causes it once they're outside and using their lungs. They're supposed to transition away from it. But usually their chemoreceptors have been thought to contribute to this. So central apnea means they forget to breathe altogether, and you'll see this with some of these preterm babies is they just completely forget to breathe altogether. They go apneic, and then they'll have a bradycardia. So there's things in the NICU called A's, B's, and D's. So apneas, brady's, and desaturations. So we try to look at what happened first. Did they brady? Like, did the heart brady down first, then cause an apnea, then desaturation? Or did it start with an apnea, then brady, then desaturation? So A's, B's, and D's. And so we try to trend how many apneas, brady's, and desaturations a baby has throughout a shift or throughout a 24-hour time frame. So let's say a kid had 6 A's, B's, and D's today, and then tomorrow they had 3, right? They have 3 A's, B's, and D's. So that's a sign that this kid's getting better overall, or if they're having more and more A's, B's, and D's, or especially if they're requiring stimulation. So stimulation is where we have to go into the room, and then if they don't come out of it, if their saturations don't come up, if they don't start breathing on their own, the heart rate doesn't come back on their own, then we have to stimulate them, which is usually just irritating them, like rubbing their back or their leg or something like that, just irritating them to sort of get them to wake up, snap out of the apnea episode. And so we also will trend if they were self-stim, in other words, they came out of it by themselves, versus we had to stimulate them. We had to go in and rub their belly or rub their leg or something like that just to get them to snap out of that apnea and bradycardia. So a lot of times we'll let them self-stim if we can. If they do need us to stim, we need to chart it as well. So A's, B's, and D's are going to be big ones. That's something you want to know during your report in the NICU. Well, how many A's, B's, and D's has the CPAP kid had, or high flow kid had? And that's something that you guys will look at too for possibly starting caffeine. They're very good at starting caffeine citrate on these kids because of periodic breathing, right? So that's that methylxanthine, it's that drive to breathe that really helps them avoid a lot of periodic breathing. So you'll have central apnea, especially more common in your preterm babies. Obstructive apnea, this can happen, especially if these kids have their neck mispositioned, like what we played with in the lab with the baby's head. If it's not in the right position, if it's flexed too much or extended just too much, then you actually might cut off the gas flow to the airway. So obstructive apnea can easily happen in these kids. That's why Miss SOPA or Mr. SOPA is a good thing to do when you go into these areas if that kid's not snapping out by themselves. One of the first things you can do, reposition their head, right? Mr. SOPA. Mixed apnea can have, with both of these, obstructive and central, can happen with neonates as well. Usually it's after a central pause, so they forget to breathe, and then they come back, but their head's mispositioned, right, or their neck's mispositioned. That's usually what's going on there. Apnea is very frequent in premature infants. In fact, this is why most kids are on premature kids are on support. Most of the time, we can get them off the vent relatively quickly, depending on what's going on. And so now it's just treating them for their sort of preterm apnea or periodic breathing. So the smaller they are, just like with RDS and just like with BPD, the smaller or more premature they are, the more likely they are to have apnea. So if they're less than 1,500 grams, right, or less than 1,000 grams especially, they are most likely going to have apnea prematurity. And periodic breathing can go along with this as well. But it's a lot of this. AOP is apnea prematurity. That's what we're looking at here. During the first 7 days, it's unlikely to occur after that. So in the meantime, the big thing that we're looking at is it will resolve over time. So it's not like this kid will have this the rest of their lives. It's just while they're still preterm, while they're still brand new, this is just something that we have to deal with until their body sort of kicks out of this apnea episode overall. So that's something that we just have to tell them. It should be getting better over time. For now, we're just giving them that airway stimulation with the CPAP or high flow or non-invasive, and as well as the caffeine. So at home, kids can still go home with a little bit of this, and so they have respiratory monitors that we can put on those kids at home. The most common one is usually a pulse ox. They do have like a respiratory rate monitor and impedance. Hopefully you guys seen that in your presentation on monitoring. But it's very rare they'll actually do that impedance belt where they put it around the kid's abdomen and lower part of their chest to look at the respiratory rate. Most of the time now it's pulse oximetry. If you have apneic spells at near term babies or term babies, so late preterm or term babies, those are very abnormal, and it's something that you need to talk about, because this could be something where you're like, well, what was their APGARs? What did they have an anoxic injury? Did they have a birth asphyxia? Was their APGAR 0001, right? Could be a sign of asphyxia, and that might be why these kids are still having abnormal breathing episodes when they're not supposed to. If you start to see it occur, it could be a sign they're having a brain bleed, an intracranial hemorrhage, an IVH. It could be part of seizing, and then if they're given medication that suppresses their drive, so let's say they were given a drug that does suppress the respiratory drive, then that could easily explain why their breathing was so odd. I remember when I first started at University Hospital, when I was doing my clinicals there, they were giving kids sedation medicine for ventilator babies, and it was standard of practice. And then when I went over to Swedish in PSL, they weren't giving any sedation medication except for some Ativan and PRN. And those kids ended up getting off the vent faster, having less A's, B's, and D's, because we weren't messing up their drive to breathe with sedation. And those kids tended to tolerate it just fine. So it's one of those things where overall, if we decrease the use of depressant medicines, then that helped avoid a lot of the apnea issues for these babies. But term babies, if you see a term baby having it, there's something bad going on. That's a pattern that hopefully the care team knows about, and if not, that's something to discuss with the rest of the care team in the NICU. Etiology is just going to be a depression of the central drive. So premature infants are more likely to have issues here. They spent 80% of their time sleeping. Hopefully most of that's in REM cycle, because they're developing their brain, they're developing their thoughts, they're developing their brain's functions. Their core movement is still developing as well, but now they're trying to develop the higher thinking parts of their brain. the more anterior sections, I should say, less brainstem functions, less lizard brain, more high functioning brain. So most of that's going to be spent usually, hopefully, in REM sleep. And so it's hard for them when you talk to, in advanced diagnostics about sleep disordered breathing. It's REM when most of these things happen, because the REM will paralyze the muscles or send no signals from the brain to the muscles, and therefore the airway becomes more floppy. You have a lot more issues here, and this is where we might see more of the apnea prematurity, is when these babies are REM sleeping. That's why stimulating them, if we have to stimulate them versus a self-stim, will usually work. It'll take them out of that deep REM sleep into a light stage and or a really angry awake stage. That's always fun for the parents, especially when they see us doing that. So they have that transition that can make it hard for them, and therefore with the muscle weakness and the deep REM sleep, the muscles aren't able to maintain patency. They'll have that sort of mixed apnea going on. Also, we need to look at their temps. The good news is most of the isolates out there will have a temperature probe where we can put it on the baby's skin, a little ducky or something like that that we put on the baby's abdomen, and then it servos to the isolate, and then it tells the isolate to heat or cool. If we see it doing a lot of things where it's telling it to cool, that could be a sign the kid's actually running at temperature, or we might have billy lights on the kids. We might actually have to open the doors of the isolate so that kid avoids hyperthermia. So temperature instability, so we'll check the baby's temp, see if that's not what's causing it. Neurological, especially, that's why it's good to know what their APGAR is. Why were they born early? You should be getting that report, just like when you get report on your patients for the adult side of things. You want to know why they're in the hospital. Do they have COPD and now they have a pneumonia and that's why they're here? That's why they're getting what they're getting. So that's what you want to know here. Why were they born premature? What's going on? Is there any hemorrhaging going on, right? What were their APGARs, right? What drugs are they getting? Are these drugs likely to cause depressants? Pulmonary, do they have a pulmonary disease? That's always good to know on your neonate. If they do have an RDS, if they do have a neonate pneumonia, like a chemical pneumonitis from a meconium aspiration syndrome, then that's something that you need to know, because you know that's not going to be as responsive to surfactant replacement therapy, so we know we're going to have to use different interventions than surfactant replacement therapy if the kid's oxygen requirements go up. Do they have BPD, right? Do they have a history of RDS, BPD? Did they have pulmonary hemorrhage from a left to right shunt, or pulmonary hemorrhage from a trauma? Do they have an obstructive airway lesion going on, laryngeal web? Do they have, a history of a pneumothorax? Things like that. Cardiac difficulties could cause this too. Usually it's congenital, and hopefully you'll know about these beforehand, but it's those congenital cardiac disorders. Also, if their blood pressure is super low, obviously you're not going to breathe very well if your blood pressure is super low. Hypertension, that can cause too much blood flow going through there, and also cause a shunting effect as well. Heart failure, if their PDA is open, then that could cause a big issue too, because now we have a left to right shunt, and therefore pulmonary edema, therefore decreased oxygenation, therefore more likely to have apneas and bradycardias and desaturations. Are they anemic? Are they polycythemic? Did they just get a blood transfusion? Or were they a traumatic issue? Or did they have to the point where we took so many labs on these neonates that they actually became anemic? Because their total blood volume is very, very low. So where you're looking at a higher chance for anemia for these kids. Is there an infection? What's their white blood cells? What's their bands to segments ratio? Right, this is something. Are they left shifted, not with the oxyhemoglobin curve, but are they left shifted with their immature to mature white blood cells? If there's more immature than mature, then it's a possibility of sepsis, and something that we want to look at and run labs for, not labs, cultures. Right, and then it could be something like necrotizing enterocolitis, where the gut is just dying, or there's stuff, it's just not moving, and Is their gut just sort of eating itself in there? There could be metabolic reasons for apnea prematurity. If their blood sugar is off, hypoglycemia, of course, they don't have enough energy to breathe. Hypocalcemia, right? They don't have enough electrolytes, so low electrolytes, low sodium, or if there's too much sodium, it could be a big issue. So we're going to check electrolytes. So gastral, so if they have GERD, gastroesophageal reflux, and almost 70%, this is even term babies, 70% of kids, of term babies even, have reflux. It's very, very common. That's why we have to have their heads up when they're feeding. That's why we have to make sure we keep their heads up, they're burped well, all those things, because they reflux. It could easily go into, and if you've ever had reflux, it's not a great thing, because it can actually go into their lungs, cause apneic episodes. So there's a lot of issues there when reflux occurs. So it's very possible that reflux could be happening when we see periodic breathing as well. When we're seeing diagnosing apnea prematurity, they've got to be on the monitor. So respiratory rate and pattern, usually heart rate, and then saturation should also be on the monitor. We're going to look at what preceded the apneic episode. Where did they just get a bunch of food and they refluxed? They had an apnea episode and then they refluxed after the apnea episode. Was there bradycardia associated with it? Was it just an apnea and desaturation with no bradycardia? Was there bradycardia first and then apnea, then desaturation? So you want to know who did it first. Who went first? Did the heart brady first and then cause everything else, or did the lungs brady first, right? Was it an apneic episode, then brady, then desaturation, or was it brady, then apnea, then desaturation? So we need to know who caused it, and that can help us figure out if it's a congenital heart thing versus more of a pulmonary drive to breathe thing. We'll look at their skin color. Did they get mottled? Did they get pale? Did they lose muscle tone? Did they spontaneously come out of it, right? Did they self-stimulate, is what we call it? Or did we have to resuscitate? In other words, did we have to go in there, stimulate them, rub them down, or did we have to completely resuscitate? In other words, go into an area where we might do like compressions or non-invasive ventilation. So we need to chart these things. So these are all things that we have to look at overall. So if they keep happening, you might have to do a 12-lead EKG on these neonates. That's something that we'll have to play with. Chest x-ray is, of course, something that we'll get. We'll run their lines for, culture their lines for sepsis. So there's a bunch of different things that we would do in the meantime. Central apnea, period of breathing for 20 seconds or longer. Usually associated with a Brady pallor, right? Pale skin. And loss of tone, so that's where they lose their muscle tone, that grimace part there. So a sudden cessation of breathing lasting at least 20 seconds, accompanied by Brady or cyanosis, is apnea of prematurity. So those are definitions. I would expect you to know those definitions. Things that we're looking at here is their chemoreceptors aren't very sensitive yet, because they're still supposed to be in utero, not outside. Their arousal response, right, still supposed to be in utero, not outside. So they're not going to know or remember that they're supposed to be on the outside. That's why we have to do that. So the way that we can help this is to stimulate their airway reflexes to avoid apnea prematurity. So you'll see a lot of kids in the NICU on high flow or CPAP just for airway stimulation. So they'll be on room air, and they'll be on room air for days. And the only reason why they're on CPAP, the only reason why they're on high flow is because of airway stimulation, because of apnea prematurity. So that's something that we can do to tell their brain, hey, you are breathing on the outside of the uterus, and so you need to keep breathing. So that actually helps avoid A's, B's, and D's. So if we start a kid on high flow and their A's, B's, and D's goes up, well, it wasn't providing enough airway stimulation. We might have to go back to CPAP or even non-invasive at that point with ram cannula or whatever that your facility wants to use. So we just need to be careful, and so that's how most of us do it. So we'll use the xanthines, so we'll use the caffeine citrate, and then as far as respiratory goes, we'll use some sort of high flow or positive pressure device like CPAP to help stimulate the airway reflexes to avoid apnea episodes. Treatments, of course, you already talked about this. Caffeine is going to be our number one thing. Usually they'll do a full dose Q day, or they'll split it in half and do it BID. There's no evidence that I'm aware of that one is superior of the other. They usually just swap in between the two. Saturation for these kids, keep it in the normal preterm, because obviously this is more common in your preterm. It's very uncommon in term, and it's a very bad sign in a term kid. So we're looking at your preterm sat range, which is 85 to 95. If it gets bad enough, we might have to put them on assisted ventilation. So nowadays, the nice thing about some of these modern ventilators is they do things with like the ram cannula, where you can still set a rate, a pip, a peep, an eye time, and the kid's just on pretty much a high flow nasal cannula looking thing, and it's giving them non-invasive ventilation. It's giving them BiPAP for all practical purposes, and they don't have to be intubated to get that ventilation assist, which is great. So if it's severe enough, we can do non-invasive. If it's still severe, then obviously we might have to go back to mechanical ventilation. Extreme flexation or extension can easily have a kid, if they're having issues where their neck position or head positioning is cutting off their airway. This is that Mr. SOPA thing. So make sure they're positioned right before you start throwing machines on these kids. Maybe it's just a positional thing first. So always pick the easiest thing first, right? Don't make any work harder for yourself than it needs to be. So instead of dragging machines into and out of rooms, maybe we can just go use the good old technique of making sure their head and neck are aligned the right place, and we'll go from there. So obviously CPAP is a place to start. 4 to 6 is usually pretty typical. So when we're putting these kids on, do they need oxygen? Usually not. We just need that stimulation. So most of the time, like I said, a lot of your NICU babies, depending on where you work, will be on room air, on CPAP, or high flow. And it's just for airway stimulation. Avoid suctioning if you can with these kids. That sort of sends them into a stunned mode, and you can have a lot of issues with it. Oral feedings can be very hard, especially if they're on CPAP or non-invasive. Not something that's done very often because they're getting a lot of flow. So usually their oral feedings are only on high flow, and even then it's pretty rare. So we can talk more about that later. Obstructive apnea. This can happen easily with choanal atresias. That's where it's closed off, and you'll see this in your chapter, in your book chapter. I think it's chapter 23. Laryngeal webbing, which where it's covering sort of the entrance to the airway. Or if their tonsils are enlarged, these can easily cause obstructive apnea to form on some of these kids. So if the kid has a laryngeal web or choanal atresia, those are something that you should hopefully know ahead of time. Or incomplete choanal atresias too can happen, where it's just mostly blocked and it's still having almost the same effect as if it was blocked. So that's something you'll have to pay attention for. So choanal atresia, the easiest way to pick that out is to try to pass a nasal catheter. If you cannot pass a nasal catheter, like a DeLee, and on both sides, and the kid breathes better when they're lying on their belly, in other words, their jaw is forward, almost like in a modified jaw thrust, just with gravity, right? Then that's a sign it could be a choanal atresia because they can't pull gas through their nose. Remember, they're obligate nose breathers, so if their nose is blocked off, of course they're going to not be able to breathe well unless their tongue and everything's out of the way. So these kids, usually we'll place them on their bellies. Look there. the natural jaw thrusting happen, they'll have to usually go get a surgery. Laryngeal webs, usually that's a surgical intervention as well, just supportive care until then. Obviously, you can't put a kid with tracheal atresia on nasal CPAP, right? You cannot, wouldn't do anything, just back pressures. So you just have to support them. If a kid has enlarged tonsils, we need to figure out why their tonsils are enlarged. Treatments, antihistamines or decongestants actually may help in some of these kids if their nasopharynx is swollen or plugged off or clogged. Need to use good humidity with our equipment as well. Surgery to remove obstructions like the cranial atresias or webs. In nasal CPAP, if it's something like an enlarged tonsil or anything like that, we still can use nasal CPAP. But if you're asked later on if you can use nasal CPAP with the cranial atresia, please say no. All right, now into the infection side of things. NICU is a great world because it's very rare that we get infections up there. When we do, it's a pretty big deal. These kids are immunocompromised. They don't have the ability to make or fight off a lot of infections because most of them are preterm that are up there. So you need to take good precautions. You're not wearing rings, you're not wearing watches, you're not wearing anything on your hands, anything below your elbows. You are not wearing fake nails. Your nails are the cleanest they've ever been. They are trimmed. You cannot have or wear anything below your elbows. No watches, no rings, like I said. None of that stuff. That's a big no-no for a lot of NICUs. So just be ready for when you go to NICU clinicals that they may ask you to remove watches and rings and stuff like that. So something just to be prepared for there. Gloves, make sure any contact with blood, you're drawing a blood gas on these kids. Bodily fluids, things like that, you're going to make sure you're going to be wearing gloves for these procedures. One of the really nice things about the NICU is every single room or every single area has really good hand washing, and they're all stocked with soap. In the adult world, not so much, maybe more nowadays, but in my experience, the adult world, not many people actually washed their hands. They just used the foam or the gel. The great thing about up there is everybody generally washes their hands, so it's really, really nice. So wash your hands in between patients. If there's one thing a nurse is going to get you on or RT on, it's washing their hands. I never got in trouble for it because I always washed my hands. So if you wash your hands, instead of using the gel or the foam in between these babies, the nurses see that. They notice it. They know they can trust you. They know you're not a vector, or they know you're not spreading those diseases. When they're doing lines, especially contact with blood and secretions, that's something that they recommend wearing a mask for. Mouthpieces doing mouth-to-mouth, not something we traditionally do in the hospital. But they want you to wear a mouthpiece if you do ever have to do it. Infections, most of them can be acquired either in utero, during delivery, or post-delivery, right? Those are the three options here. You can get it in utero through the placenta or birth canal, right? We talked about that with the herpes, where they can get that through the birth canal, and that's one of the indications for a C-section is actually if the mom has a active herpes going on, that's actually an indication for a C-section. So in utero, that's something that we may have to actually deliver the baby early for if their biophysical profile is looking poor. During delivery, if they come in contact with stuff through the birth canal, that's what we're talking about with like herpes, things like that, can easily do that. As well as post-delivery, that's us. Make sure you clean our equipment, all that stuff good. Personnel, equipment, line infections, things like that could easily happen. So we'll start with bacterial infections. Often these are caused in utero. They're from things like a premature rupture of membrane is going to be one of your first ones. So if you have a prom mom, they'll treat mom with antibiotics or baby with broad spectrum antibiotics initially, or they may wait and be more conservative and wait and then see if the kid shows signs of infection. Then they'll start broad spectrum antibiotics, because most likely bacterial, because they were a prom baby. So this bacteria enters the mouth and the lungs, the GI tract, and this causes what's called choreo or chorioamnioitis. So we just call it choreo up there. And choreo is a bacterial infection. So if you hear them talking about choreo, it's a bacterial infection. Is there a history of problem with that baby? Right? Could that be causing their issues overall? Also, instead of it being caused from premature rupture of membranes, it could be from infected equipment. So that's ventilating equipment, that's nursing equipment, that's a bunch of different types of equipment. So we need to make sure we're processing that stuff really well. Remember, their immune systems are very, very weak, especially these premature babies. So you miss something, you barely wiped something down, that could be a very, very costly mistake. So that was bacterial viral infection signs that a kid might have a virus going on, and hopefully not. These are very, very bad for a lot of these kids. Failure to thrive. They're not going to want to eat. They're not going to want to move. They're not going to want to be moving around. Their tone will be a little poor. These kids tend to not meet milestones. They're not developing as well as they should. They're not gaining weight as well as they should. Their stools will be extremely loose. They're not going to be functioning well neurologically to responses. You might see oral candida, so that's that white spot, just like you see someone doesn't rinse their mouth out after their steroids, so on and so forth. And then sepsis could be one of the things that goes on with a viral infection on these kids. So when a neonate gets a virus, it's a very, very severe thing. So some of the viruses that you could see, HIV/AIDS, of course, the risk would be from an infected mom. So they can get it in utero across the placenta. It's very rare, but it's possible. But not all HIV positive moms will transmit to baby, and so it's pretty cool. I remember looking up the CDC statistics on HIV, and if they give mom the antivirals for an infection, then her delivery risk of transmitting to the baby is very low, and I believe it was less than 10% the last time I looked up that statistic, and I haven't looked it up in a little while here, but so it's very, very low, and that's usually going to be a C-section to avoid tears and all this other stuff. So what is their level of HIV? Is it active or latent? How much exposure during a pregnancy did the baby have? So was mom on antiretrovirals? These are all things that will factor into how significant that is. Outcomes, once the baby's diagnosed with immunodeficiency, survival is still pretty low. I have not looked up an updated statistic on that recently. Rubella, more common than HIV positive. In my practice, more common. This can cause congenital abnormalities. So they'll talk about being rubella immune, so on and so forth. That's something that we actually talk about at deliveries when we're giving a report with the nurses or the new baby nursery or well baby nurses now or whoever. So rubella is something we talk about. This can cause congenital abnormalities, so if they do have it, that's something that we have to screen them for, or we might screen them for. Usually it's within that first 5 months of gestation. We might be able to see some of those things on genetic testing and or ultrasound. Cytomegalovirus. Notice that we're going through the torch stuff. Cytomegalovirus, obviously a virus. This can be from a form of herpes transmitted through the placenta. So that's something that can be very harmful to babies. So we do not treat if they're pregnant because that can be very fetal toxic. The big thing with these babies or suspected babies to wear gloves when we're handling secretions. A lot of these babies will have just an IUGR, which means if they're 40 weeks, they might be only 35 weeks sort of mature. So remember, IUGR is growth restriction, so they won't mature. They'll be immature for what their gestational age is. High bilirubin levels, so they're more prone to jaundice, right? Liver damage, of course, that can go along with that. Microcephaly, so small head. Brain damage, of course, and then even hearing loss can all be part of that. Herpes, usually there's two types out there, the lips and the upper body, and then type 2 can be contracted by neonates through the birth canal. That's why if mom has active herpes, it is a C-section baby. They elect to do a C-section with these babies. Neonates with disseminated herpes have a high mortality rate. Non-disseminated usually have a lower mortality rate, and I'm not going to test you on those statistics, but just looking at that. Herpes, symptoms of herpes, if it's disseminated versus non-disseminated. Disseminated, large liver, there'll be jaundice, lots of lesions, their neurological responses are going to be very, very poor. Diagnosing non-disseminated, usually it's the eye, skin, and some CNS activity, but that's where it's being differentiated between disseminated and non-disseminated. Diagnosing, they're going to culture the lesions, send those to the lab. Treatments, acyclovir is going to be the big one here, and then keep on testing overall. And finally, the last one would be a protozoal infections, and the big one here is going to be toxoplasmosis. So toxoplasmosis is contracted by mom. This is why mom should not be touching raw meat or doing anything with cat feces. So if you see a pregnant mom doing either of those, that can be a risk factor that is faced. Usually it's transmitted in the 3rd trimester, so these kids will be term or near term, so late preterm or term babies, and they'll have some sort of infection going on, and it's not bacterial, it's not viral, well, it could be that protozoal, and that's just a factor that they can easily